Let's begin our session on dengue fever with a clinical case. A 17-year-old male presents to the emergency department with concerning symptoms. He has high-grade fever, facial flushing, and skin erythema, which is generalized redness of the skin. He complains of myalgia, which is muscle pain, arthralgia, meaning joint pain, severe headache, sore throat, loss of appetite, nausea, and vomiting. The critical piece of history is that he recently returned from a trip to Brazil, a dengue endemic area. His vital signs are revealing. Heart rate is elevated at 110 beats per minute, indicating tachycardia. Respiratory rate is 20 per minute, slightly elevated. Blood pressure is 100/60 millimeters of mercury, which is on the lower side, suggesting possible fluid depletion or early shock. His temperature is markedly elevated at 39.4 degrees Celsius. Physical examination reveals several important findings. The tourniquet test is positive, which indicates capillary fragility and is a warning sign for dengue. A maculopapular rash is present, which is a characteristic rash with both flat and raised areas. Multiple petechiae, which are tiny pinpoint hemorrhages, are visible on the trunk, indicating bleeding tendency. Abdominal tenderness in the right upper quadrant suggests possible liver involvement or hepatomegaly. This constellation of findings, fever, travel history, rash, positive tourniquet test, and petechiae, strongly suggests dengue fever, with warning signs requiring careful monitoring for progression to severe dengue. Dengue virus is classified into 4 distinct serotypes designated DEN1, DEN2, DEN3, and DEN4. All 4 serotypes belong to the genus Flavivirus within the family Flaviviridae. This classification is crucial because infection with one serotype provides lifelong immunity to that specific serotype, but only temporary cross-protection against the other 3 serotypes. Within each of the 4 serotypes, distinct genotypes have been identified based on genetic variation. These genotypes show geographic distribution patterns and differ in their pathogenic potential. Importantly, certain genotypes are associated with more severe disease. Specifically, the Asian genotypes of DEN2 and DEN3 are frequently associated with severe disease, particularly during secondary dengue infections. This is clinically significant because it helps explain why dengue in Southeast Asia, including Malaysia, often presents with more severe manifestations. The existence of 4 serotypes has important implications. First, it means people can potentially get dengue up to 4 times in their lifetime, once with each serotype. Second, and more concerning, secondary infection with a different serotype often results in more severe disease due to a phenomenon called antibody-dependent enhancement, which we'll discuss later. This is why dengue is such a challenging public health problem. Prior infection doesn't provide complete protection, and may actually predispose to more severe disease upon subsequent infection with a different serotype. Dengue virus contains a RNA genome and it's spherical in shape with an envelope. Embedded in this envelope are viral glycoproteins, particularly the E protein or envelope protein, and M protein or membrane protein. Looking at the schematic structure, you can see the envelope surrounding the core. The envelope protein E is the major surface protein and is responsible for several critical functions. It binds to cellular receptors, facilitating viral entry into cells. It also mediates fusion between viral and cellular membranes, allowing the viral genome to enter the cytoplasm. The E protein is the primary target of neutralizing antibodies, making it important for vaccine development. The envelope also contains the M protein, which is involved in viral assembly and maturation. Inside the envelope is the nucleocapsid, consisting of the RNA genome surrounded by multiple copies of the capsid protein C, which protects the viral genetic material. The source of dengue virus is infected humans. Unlike some other mosquito-borne diseases where animals serve as reservoirs, dengue virus circulates in a human-mosquito-human cycle. When a person is infected with dengue, they develop viremia, meaning the virus circulates in their blood, typically from 1 day before fever onset to about 5 to 7 days after. During this viremic period, they can serve as a source of infection for mosquitoes. The mode of transmission is through the bite of infected female Aedes mosquitoes. Only female mosquitoes bite, because they require blood meals for egg production. When a female Aedes mosquito bites a viremic person, it ingests blood containing the virus. The virus then replicates in the mosquito's midgut and spreads to its salivary glands over 8 to 12 days. Once the virus reaches the salivary glands, the mosquito can transmit dengue to other people through subsequent bites. Importantly, once infected, the mosquito remains infectious for life. The primary vector of dengue virus is Aedes aegypti, which is highly adapted to urban environments and prefers to bite humans. This mosquito breeds in clean, stagnant water found in artificial containers, like flower vases, water storage containers, discarded tires, and any items that can collect rainwater. Aedes aegypti has distinctive white markings on its legs, and a lyre-shaped pattern on its thorax. The secondary vector is Aedes albopictus, also called the Asian tiger mosquito, due to its black and white striped appearance. While less efficient at transmitting dengue than Aedes aegypti, it's more adaptable to different environments, and can survive in both urban and rural settings. Both species are daytime biters, with peak biting activity in early morning and late afternoon. The World Health Organization revised dengue classification in 2009 to better reflect clinical reality and guide management. Understanding this classification is essential for appropriate patient triage and treatment. The current WHO classification divides dengue into two main categories based on severity: dengue without warning signs, dengue with warning signs, and severe dengue. Dengue without warning signs represents mild disease. Patients have fever with two or more of the following: nausea and vomiting, rash, aches and pains like myalgia and arthralgia, positive tourniquet test, or leukopenia, which is low white blood cell count. These patients can usually be managed as outpatients with careful monitoring. Dengue with warning signs indicates patients at risk for progression to severe disease requiring hospitalization and close monitoring. Warning signs include abdominal pain or tenderness, persistent vomiting, clinical fluid accumulation like pleural effusion or ascites, mucosal bleeding such as nosebleeds or gum bleeding, lethargy or restlessness, liver enlargement, and laboratory findings of increasing hematocrit with rapid decrease in platelet count. Severe dengue represents life-threatening disease requiring intensive care. It's defined by the presence of any of the following: severe plasma leakage leading to shock or fluid accumulation with respiratory distress, severe bleeding requiring blood transfusion, or severe organ impairment affecting liver with AST or ALT greater than 1,000, impaired consciousness, or heart and other organ involvement. Dengue shock syndrome represents severe plasma leakage leading to hypovolemic shock. The pathophysiology involves massive increase in vascular permeability, causing plasma to leak from blood vessels into surrounding tissues. This results in decreased circulating blood volume, leading to shock. Patients present with signs of circulatory failure, including cold, clammy extremities, rapid weak pulse, narrow pulse pressure with systolic blood pressure minus diastolic blood pressure, less than 20 millimeters of mercury, hypotension, and altered mental status. Without prompt fluid resuscitation, dengue shock syndrome can be fatal. Severe hemorrhage represents the bleeding manifestations of dengue. While minor bleeding like petechiae or mucosal bleeding is common in dengue, severe hemorrhage is life-threatening. Mechanisms include thrombocytopenia with very low platelet counts, platelet dysfunction, vascular fragility from plasma leakage, and possible disseminated intravascular coagulation in severe cases. Severe hemorrhage manifests as gastrointestinal bleeding with hematemesis or melena, vaginal bleeding, intracranial hemorrhage, or bleeding requiring blood transfusion. An important epidemiological observation is that secondary infections lead to more serious disease. This phenomenon is explained by antibody-dependent enhancement. The most dangerous sequence is DN1 infection followed by DN2 or DN3 infection, or DN3 infection followed by DN2 infection. The pre-existing antibodies from the first infection, instead of protecting, actually enhance infection during the second encounter with a different serotype, leading to higher viral loads and more severe disease. The pathogenesis begins when dengue virus is inoculated into skin through an infected mosquito bite. The virus initially infects skin dendritic cells, specifically Langerhans cells, and dermal dendritic cells. These infected dendritic cells migrate to local lymph nodes. In lymph nodes, and subsequently in the bloodstream, dengue virus primarily targets and replicates in cells of the monocyte macrophage lineage. The virus binds to cellular receptors on monocytes and macrophages and enters through receptor-mediated endocytosis. Once inside, the virus uncoats, releases its RNA genome, and uses the host cell machinery to replicate, producing thousands of new viral particles. The infected monocytes and macrophages release massive amounts of cytokines and inflammatory mediators. This cytokine storm includes tumor necrosis factor alpha, interleukin-1, interleukin-6, and interferon gamma. These cytokines have several effects. They cause fever, the hallmark symptom, by acting on the hypothalamus. They increase vascular permeability, leading to plasma leakage that characterizes dengue. They activate the complement system and coagulation cascade, contributing to bleeding tendency. The virus also infects liver cells, or hepatocytes, causing hepatocellular damage manifesting as elevated liver enzymes and hepatomegaly. Bone marrow suppression occurs, leading to thrombocytopenia and leukopenia. Endothelial dysfunction is central to dengue pathogenesis. The virus and inflammatory mediators cause endothelial cell activation and increased permeability. This leads to plasma leakage from blood vessels into interstitial spaces, causing hemoconcentration, pleural effusions, and ascites. In severe cases, massive plasma leakage leads to shock. The immune response eventually controls the infection through neutralizing antibodies and cytotoxic T cells, leading to viral clearance and recovery in most cases. Antibody-dependent enhancement, or ADE, is a unique and concerning phenomenon in dengue that explains why secondary infections are often more severe. The process begins with primary dengue infection. When a person is first infected with one dengue serotype, let's say DEN1, their immune system produces antibodies specific to that serotype. These neutralizing antibodies provide lifelong immunity against DEN1. However, these antibodies also cross-react weakly with other serotypes, providing only temporary partial protection for a few months. When the same person later gets infected with a different serotype, for example DEN2, the pre-existing antibodies from the first infection bind to the new virus. However, instead of neutralizing it, these antibodies are non-neutralizing or subneutralizing. They can bind to the virus but cannot effectively prevent infection. Here's where the problem occurs. The antibody-virus complexes bind to Fc receptors on monocytes and macrophages. Fc receptors normally recognize antibodies and help clear pathogens. However, in this case, the antibody-coated virus uses the Fc receptor as a Trojan horse to enter monocytes and macrophages more efficiently. This actually enhances viral entry into these cells. The result is higher viral loads with more cells infected, leading to greater cytokine release and more severe inflammation. This manifests clinically as increased vascular permeability, causing severe plasma leakage and shock, higher risk of hemorrhage from more severe thrombocytopenia, and greater organ damage. This ADE phenomenon has important implications. It explains why dengue can be more severe during second infections. It complicates vaccine development because a vaccine must provide balanced immunity against all four serotypes to avoid creating a situation where partial immunity enhances disease. It also explains why certain serotype sequences are more dangerous. Severe dengue. A patient enters what is called the critical phase, normally about 3 to 7 days after illness onset. During the 24 to 48 hours of critical phase, a small portion of patients may manifest sudden deterioration of symptoms. It is at this time, when the fever is dropping below 38 degrees Celsius (100 degrees Fahrenheit) in the patient, that warning signs associated with severe dengue can manifest. Severe dengue is a potentially fatal complication due to plasma leaking, fluid accumulation, respiratory distress, severe bleeding, or organ impairment. Severe dengue is defined by dengue with any of the following symptoms: severe plasma leakage leading to shock or fluid accumulation with respiratory distress, severe bleeding, or severe organ impairment such as elevated transaminases is greater than or equal to 1000 IU/liter, impaired consciousness, or heart impairment. This diagram illustrates the progression and clinical features of severe dengue, representing the most critical phase requiring intensive medical management. Severe dengue typically develops during the critical phase, which occurs around days 3 to 7 of illness, often paradoxically as fever starts to subside. This is when plasma leakage is most pronounced. The manifestations fall into 3 main categories. Severe plasma leakage leads to accumulation of fluid in body cavities. Patients develop pleural effusions, fluid in the chest cavity causing shortness of breath and reduced breath sounds. Ascites or fluid in the abdominal cavity causes abdominal distension. Pericardial effusion, though less common, can occur. The combination of massive plasma leakage with inadequate fluid replacement leads to hypovolemic shock or dengue shock syndrome, characterized by cold extremities, rapid weak pulse, hypotension, and altered consciousness. Severe bleeding represents the hemorrhagic manifestations. While minor bleeding is common, severe hemorrhage is life-threatening. This includes hematemesis, which is vomiting blood, melena, or black tarry stools indicating gastrointestinal bleeding, severe menstrual bleeding in women, or internal bleeding in organs. The mechanisms include severe thrombocytopenia with platelet counts below 20,000, platelet dysfunction, consumption coagulopathy, and vascular fragility. Severe organ impairment indicates multi-organ involvement. Liver impairment manifests as jaundice and markedly elevated transaminases, often exceeding 1,000 units per liter. Acute kidney injury can occur from shock and reduced renal perfusion. Myocarditis, or heart muscle inflammation, can cause arrhythmias and heart failure. Encephalitis, or brain inflammation, causes impaired consciousness, seizures, or other neurological manifestations. Warning signs that predict progression to severe dengue include persistent vomiting, preventing oral hydration, severe abdominal pain, mucosal bleeding, lethargy or restlessness, rapid drop in platelet count with rising hematocrit, and liver enlargement. The specimens required vary based on disease stage and clinical situation. For active cases with acute illness, blood is the primary specimen. Serum or plasma is separated for testing. The timing of sample collection is crucial because different diagnostic markers are present at different disease stages. For post-mortem cases when dengue is suspected as the cause of death, tissue samples from liver, spleen, lymph nodes, and other organs can be obtained during autopsy for viral detection and histopathological examination. 3 categories of viral markers are used for dengue diagnosis, each with different detection windows. Viral genome detection identifies viral RNA directly in the specimen, useful during the first 5 days of illness when viremia is present. The method used is reverse transcription polymerase chain reaction, or RT-PCR, which is highly sensitive and specific. Viral antigen detection identifies viral proteins in the specimen. The most important is NS1 antigen or non-structural protein 1, which is secreted by infected cells and circulates in blood. NS1 antigen can be detected from day 1 up to day 9 of illness, covering both early and slightly later phases. This makes NS1 testing particularly useful. Antibody detection identifies the host immune response to infection. IgM antibodies appear around day 4 to 5 of illness and can persist for 2 to 3 months, indicating recent infection. IgG antibodies appear later, around day 7 to 10, and persist for life, indicating past infection. The pattern of IgM and IgG helps distinguish primary from secondary dengue infections. NS1 antigen is a highly conserved glycoprotein essential for dengue virus viability and replication. Unlike structural proteins that form the virus particle, NS1 is involved in viral RNA replication and immune evasion. Importantly, infected cells secrete NS1 into the bloodstream, where it circulates at high concentrations during acute infection. NS1 antigen is present in high concentrations in the sera of dengue-infected patients during the early phase of disease, from day 1 up to approximately day 9 of illness. This detection window overlaps with the viremic period and extends slightly beyond, making it useful throughout the febrile phase. The test most commonly used for NS1 detection is lateral flow immunoassay, also called immunochromatographic test, or ICT. This is a rapid point-of-care test based on antigen-antibody binding. The test uses specific monoclonal antibodies against NS1 that are fixed on a test strip. When serum containing NS1 is applied, the antigen binds to the antibodies, producing a visible colored line on the test strip. The advantages of NS1 testing are significant. It's the most rapid dengue diagnostic test currently available, with results typically available within 15 minutes. This speed is crucial for early diagnosis and appropriate patient management. The test is simple to perform, requiring minimal training and no specialized equipment. It can be performed at point-of-care settings, including clinics and emergency departments. It has good sensitivity and specificity during the early phase of illness. It doesn't require differentiation between primary and secondary infection for a positive result. Currently, there is no specific antiviral drug available for dengue treatment. This absence of targeted therapy makes supportive care the cornerstone of dengue management, with the goal of preventing progression to severe disease and managing complications. The fundamental principle of dengue treatment is to maintain and monitor hydration status carefully. Appropriate fluid management is critical because dengue pathophysiology centers on plasma leakage. Patients must receive adequate fluids to maintain circulating blood volume and prevent shock. However, excessive fluids can cause fluid overload and complications like pulmonary edema. The balance is delicate and requires careful monitoring. For dengue without warning signs, patients can receive oral rehydration solutions at home with clear instructions to return if warning signs develop. Recommended fluid intake is 2 to 3 liters per day for adults. Close monitoring of symptoms, vital signs, and warning signs is essential. For dengue with warning signs, hospitalization is required. Intravenous fluid therapy with isotonic crystalloid solutions like normal saline or Ringer's lactate is initiated. Fluid rates are adjusted based on clinical response, hematocrit levels, and vital signs. The critical phase typically lasts 24 to 48 hours, requiring intensive monitoring including hourly vital signs, urine output measurement, hematocrit and platelet monitoring every 4 to 6 hours, and assessment for fluid accumulation. For severe dengue including dengue shock syndrome, aggressive fluid resuscitation is required. Initial fluid boluses of 10 to 20 milliliters per kilogram are given rapidly, followed by careful titration based on response. Blood products including packed red blood cells, platelets, and fresh frozen plasma may be necessary for severe bleeding or coagulopathy. Symptomatic treatment includes acetaminophen for fever and pain relief. Acetaminophen is preferred because it doesn't affect platelet function or increase bleeding risk. Aspirin and nonsteroidal anti-inflammatory drugs are contraindicated because they inhibit platelet function and increase bleeding risk. Dengue prevention includes both vaccination and vector control. Let's first discuss the dengue vaccine, which represents a significant advance though, with important limitations. CYD-TDV, commercially available as Dengvaxia, is the first dengue vaccine to be licensed. The name stands for chimeric yellow fever dengue, live attenuated, tetravalent dengue vaccine. It was first licensed in Mexico in December 2015 for use in individuals 9 to 45 years of age living in endemic areas and is now licensed in 20 countries. The vaccine is a live recombinant tetravalent vaccine, meaning it contains 4 live attenuated viral strains, 1 for each dengue serotype. The technology uses a yellow fever virus backbone with dengue virus envelope proteins, creating a chimeric virus that provides immunity to dengue without causing disease. The vaccination schedule involves a 3-dose series, administered on a 0-6-12-month schedule, meaning doses at enrollment, 6 months later, and 12 months after the first dose. Completing all 3 doses is necessary for adequate immunity. Critically important, the vaccine is used only in people previously infected with dengue, meaning those who are dengue seropositive. This restriction exists because clinical trials showed that in dengue seronegative individuals, those who had never been infected before, vaccination increased the risk of severe dengue if they subsequently got infected naturally. This phenomenon relates to antibody-dependent enhancement. The vaccine creates partial immunity that, in previously unexposed individuals, can enhance, rather than prevent disease during subsequent natural infection. Therefore, before vaccination, individuals should be screened for prior dengue infection through serological testing. The vaccine provides additional protection for those previously infected but should not be given to dengue-naive individuals. The first strategy is preventing mosquitoes from accessing egg-laying habitats through environmental management and modification. Aedes mosquitoes breed in clean, stagnant water collected in artificial containers. Environmental management aims to eliminate these breeding sites. This includes proper urban planning and design that prevents water accumulation, improving water supply systems so people don't need to store water in open containers, and proper drainage systems preventing water pooling. The second strategy involves disposing of solid waste properly and removing artificial man-made habitats. Common breeding sites include discarded tires, plastic containers, bottles, cans, and any debris that can collect rainwater. Community cleanup campaigns to remove these potential breeding sites are essential. Proper waste management systems ensuring regular garbage collection prevent accumulation of containers that mosquitoes can exploit. The third critical strategy is covering, emptying, and cleaning domestic water storage containers on a weekly basis. In many settings, particularly where water supply is intermittent, people store water in containers. These become major mosquito breeding sites if not properly managed. The Aedes mosquito life cycle from egg to adult takes about 7 to 10 days, so weekly cleaning interrupts this cycle. Containers should be covered with tight-fitting lids to prevent mosquito access. They should be emptied completely, at least weekly, and the inner surfaces scrubbed to remove eggs adhering to walls, which can survive for months in dry conditions. The fourth approach involves applying appropriate insecticides to outdoor water storage containers. For containers that cannot be covered or emptied frequently, larvicides can be added to kill mosquito larvae while keeping water safe for domestic use. Continuing with vector control strategies, let's examine personal protection measures and community-based interventions. Personal and household protection measures reduce human-mosquito contact. Installing window screens on all windows and doors prevents mosquitoes from entering homes. Where screens are not feasible, insecticide-treated materials including bed nets, curtains, and screens provide protection, particularly during daytime when Aedes mosquitoes are most active. Mosquito coils and vaporizers containing insecticides can be used indoors to repel or kill mosquitoes. Wearing long-sleeved clothes and long pants during peak mosquito biting times, especially early morning and late afternoon, reduces skin exposure. Using insect repellents containing DEET, picaridin, or other effective ingredients on exposed skin provides additional protection. Improving community participation and mobilization for sustained vector control is crucial because Aedes mosquitoes breed in residential areas, making household and community involvement essential. Health education campaigns raise awareness about dengue transmission and prevention. Community cleanup activities organized regularly remove breeding sites. Empowering communities to conduct their own mosquito surveys and elimination activities creates ownership and sustainability. School-based programs educate children, who then influence family behaviors. Applying insecticides, as spray spraying during outbreaks, represents emergency vector control measures. When dengue cases surge, spray spraying with insecticides targets adult mosquitoes, temporarily reducing populations and interrupting transmission. However, this is not a long-term solution and should complement rather than replace environmental management. Spray spraying is most effective when done strategically in areas with active transmission. Active monitoring and surveillance of vectors determines the effectiveness of control interventions. This includes regular surveys of mosquito populations, measuring larval indices like house index and container index, monitoring insecticide resistance in mosquito populations to guide insecticide selection, and tracking mosquito abundance over time to evaluate control program impact.